There we are. See, I just tried for the third time and it worked, or for the fifth time and it worked. Can you hear and see me? Okay. Any questions or concerns? Let's just jump into things then.
Yeah. She sleeps with me.
I know it does. Mommy says when you open up the door, open the gate.
So I want to try to get through most of chapter 13 today.
Thought you guys were awake.
But she wants to learn seriously.
It just doesn't care.
So talked about different tracks, talked about the fact that we have sensory nerves, we have motor nerves, and we have mixed nerves that contain both sensory and motor. A ganglion is a, I just took her out. Okay. A ganglion is a cluster of neurosomes, or remember, that's also cell bodies of neurons outside of the central nervous system. Among these clusters are bundles of nerve fibers that lead into and out of a ganglion. The posterior root ganglion is the one that we think of most right now, and that is also the dorsal root ganglion. It's associated with the cell bodies of sensory afferent neurons. We also call it the dorsal root ganglion. Remember, posterior and dorsal mean the same thing. So here's our spinal nerve that's going to ultimately enter into the, it's going to ultimately, actually here, it's going to ultimately enter into the dorsal horn. So it's a dorsal root that's going to enter into the dorsal horn. The anterior root is coming out the anterior horn. So this is a cross section. You can't really see it there. This is a cross section of it right here. So here's the spinal root. Here's the posterior root. Here's the spinal nerve. Here's the posterior root. Here's the anterior root. Here's the dorsal root ganglion, or the posterior root ganglion, containing the cell bodies of sensory neurons. Remember, the anterior root is what's got motor neurons in it. Posterior root contains sensory neurons. So each spinal root is formed from two roots: the dorsal root ganglion, which is the sensory input into the spinal cord, and the dorsal root ganglion contains the somas of the cell body of the neurons carrying signals to the spinal cord. 6 to 8 rootlets are going to leave that dorsal root ganglion and enter into the posterior dorsal horn of the spinal cord. The anterior ventral root is the motor output out of the spinal cord, which contains 6 to 8 rootlets that are going to leave the spinal cord and converge to form the anterior root. So remember, dorsal is sensory, or posterior is sensory. Anterior or ventral is motor. Posterior ramus, you remember from talking about bones in the lab, the mandible, the ramus of the mandible is an arm. Posterior ramus is an arm coming off the spinal nerve. Posterior ramus is a branch of each spinal nerve that's going to innervate certain parts of the skin, muscles of the neck, and deep muscles of the back. Looking right here, here's the dorsal root ganglion. Here's the posterior ramus.
Can I ask a question?
Go ahead.
It says the branch of each spinal nerve that innervates certain parts of the skin. I'm just a little confused about what it means by innervates.
Innervates meaning it's involved with the sensory of that area.
Okay.
So it's what is going to bring in or bring in or take out signals to that area, specific area. Yeah, that's a good question. So anything that innervates, any nerve that innervates a certain area, that's the area that nerve is responsible for. That part of the nerve is responsible for. So the posterior ramus of each spinal nerve is going to innervate certain parts of the skin, the muscles of the neck, and deep muscles of the back, meaning it's responsible for innervating those regions. Does that help, Brianna?
Yeah, it does. That makes sense.
Okay. The anterior rami, especially of the spinal nerves, of the thoracic area, is going to give rise to the intercostal nerves. Intercostal meaning in between the ribs. So costal meaning ribs, intercostal meaning the nerves in between the ribs. And the muscles of that are involved in moving the ribs. Now, I like diagrams. I think they're great, but they never do it justice compared to real pictures. So I'm trying to include in my lectures, especially this semester and hopefully next semester too, more pictures of cadavers. Looking at this, you got to orient yourself. Here's the vertebrae body. So this is the anterior side. This is the posterior side. So here's the posterior rami. Here's the anterior rami. Here's the anterior horns. Here's the posterior horns. All this space in here is the subarachnoid space. So the arachnoid motor is about right here. The dura mater is right above it. And this little fatty area right in here is the epidural space. And like I said, we're looking through a cross section of the spinal cord. Posterior rami is going to be sensory. Anterior rami is going to be motor. You know, a different looking, rather than a transverse section, now we're just looking at a frontal view of it. Here's the spinal cord. Here's the dorsal root ganglion. Here's the dorsal root. Here's the ventral root. Remember, that can also be the posterior root or the anterior root. Looking here, different picture, almost the same material. Here's the spinal cord. Here's the rootlets. Here's the dorsal root ganglion. Here is the posterior rami. Here's the anterior rami. Looking here, here's the dorsal root ganglion. Here's the posterior rami. This is my guess, just looking at this picture, this is the anterior rami. Questions? The anterior rami of the spinal nerves, anywhere except for the thoracic region. In the thoracic region, the anterior rami is going to make up the intercostal nerves. In other areas besides the thoracic region, it's going to enter into plexuses from which the peripheral nerves are going to arise that innervate the ventral and lateral body surface, including the structures in the body wall and the limbs. So the anterior rami is going to make the different plexuses of the peripheral nervous system. The rami communicantes, this little spot right here on this one, this little area right here. So the rami communicantes, this is what we call the sympathetic chain ganglion, which we'll talk about when we talk about the autonomic nervous system. And so sympathetic chain ganglion, meaning it's very much involved in the sympathetic nervous system. So the rami communicantes is a nerve that contains the axons related to the autonomic nervous system. And each one contains two rami, a white rami and a gray rami. So here's the sympathetic chain ganglion. Right next to it is the rami communicantes. So it contains the axons of the autonomic nervous system. A meningeal branch coming off of every spinal nerve is a branch that serves the vertebrae, the vertebral ligaments, and the blood vessels of the spinal cord and the meninges. A pinched nerve occurs when too much pressure is applied to a nerve by the surrounding tissues. So it can be bones, cartilage, muscles, or tendons. The pressure disrupts the nerve's function and can cause pain, tingling, numbness, or weakness. For example, a herniated disc in your lower spine can pinch a nerve root, such as your sciatic nerve, and cause sciatica. A pinched median nerve in your wrist is what results in carpal tunnel syndrome. Or the basis of carpal tunnel syndrome is a pinched median nerve. You do a lot of small wrist nerve and you irritate the tissues in the area of your wrist. And there is a very tight tendon that wraps around your wrist. And underneath it runs the muscles and the ligaments that you're irritating when you do this kind of thing. And this tendon doesn't move. It's very tight. It kind of keeps all your carpal bones and all the muscles all together in one place. And so they're all confined to that one area, and then you're irritating them and causing them to swell. They put pressure on the median nerve that also moves in that area and pinches it off. That's why carpal tunnel causes numbness and tingling. My dad, who is my computer go-to guy, because he's kind of a computer guru who can do and knows almost anything about computers. And he has had surgery on carpal tunnel syndrome 3 or 4 times. And what they do is they go in and they make little nicks in this tendon to give your median nerve a little bit more space. Dorsal roots along the spinal cord contain what kind of neurons, while the dorsal rami contain what kind of neurons?
Is it
Z.
B?
Say it again.
C.
I said B.
I think it's B.
B.
And the reason is because we know it's sensory. Dorsal roots are sensory. Dorsal rami are both. So anterior ventral rami, remember outside of the thoracic region, they're going to form plexuses. We have 5 plexuses. We have the cervical plexus. We have the brachial plexus. We have the lumbar plexus, the sacral plexus, and the coccygeal plexus. And the anterior rami in the thoracic region are going to become the intercostal nerves. The cervical plexus, which includes cervical roots, nerves C1 through C5, serves to innervate the skin and muscles of the head, neck, upper part of shoulders, and diaphragm. What is the diaphragm involved in?
Breathing.
Breathing, respiratory.
Yeah, it's your major breathing muscle. Very few, it's the major muscle involved in your breathing. that the nerve that comes off that innervates the diaphragm is the phrenic nerve. And it comes off C3, C4, and C5. Here it is right here. Coming off here, here, and here. If you get a break, if someone breaks their spinal cord or severs their spinal cord above C3, they're not going to be able to breathe on their own because they lose innervation of the diaphragm. If you remember, and this shows my age, the old Superman movies. There was a man, the actor who played in the very old Superman movies his name was Christopher Reeve. And it was kind of a big deal when he was on a horse and went to do a jump and broke his neck in between C1 and C2.
He's Superman.
He was Superman. That's why it was a big deal.
I was just talking about that with my friend the other day, actually.
Really?
Christopher Reeves falling off a horse and breaking his neck or back.
Yeah, it was his neck. And
Yeah.
and I mean it was a major blow because we know him as Superman.
Mm-hmm.
And the fact that at that point, right immediately after that, he was no longer able to breathe for the rest of his life on his own. And so the mnemonic for remembering this, C3, C4, C5, keep the diaphragm alive. So that's the major nerve that you want to remember coming off the cervical plexus. So the cervical plexus, and then C4, C3, C4, and C5 merge together to form the phrenic nerve. Injuries to the phrenic nerve, we've, as technology is getting better, and I cannot remember when he died, but I think it was like in 2010 or something to that effect. But since then, technology's gotten a little better, and we have pacemakers for the heart, but we also have pacemakers that can stimulate a phrenic nerve. And what they do is they provide a ventilation support for patients with chronic respiratory insufficiency, whose diaphragm, lungs, and phrenic nerves may have some residual function. This is used for quadriplegics, like what we saw with Christopher Reeves, congenital central hypoventilation syndrome, diaphragm paralysis, brainstem stroke, and brain injury and brain tumors. So instead of using a ventilator that's constantly forcing air into the lungs, a phrenic pacemaker enables the diaphragm to contract and relax and allow for the patient to inhale more naturally. So rather than having to constantly force air into the lungs, now you're firing artificially the phrenic nerve to allow it to contract and relax. And therefore, artificially stimulating the phrenic nerve to allow for the diaphragm to contract and relax. The brachial plexus is divided into roots, trunks, divisions, cords, and nerves. Nerves from the brachial plexus are going to innervate the neck, the shoulders, and the upper limbs. So this is coming off C5 to T1. major nerves coming off are the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. One thing to remember as we talk about these nerves is wherever a nerve, just like with Brianna's question earlier, anytime that a nerve passes by a region, it innervates that region. So it's once you think of the routes of muscles, and whatever muscle that it passes by, passes through, or moves by, it's going to innervate that region. So if, for example, the radial nerve, it passes by the radius. It's going to innervate the muscles that are involved with the radius and the skin around the radius. Ulnar nerve passes by on the back side of the ulna. Median nerve passes by the front of the hand, so it's going to innervate everything in that area. So a lot of times if you study the routes of nerves, you can figure out what, and then you learn the muscles, you can determine what nerve is innervating what muscles based on the fact that they're overlapping. So brachial plexus coming off C1 through C5 through T1. Injuries to the median nerve, Erb's palsy, where there's a paralysis of the arm that's often occurs when a baby's head and neck are pulled in the same direction during delivery, to pull the baby toward the side, pulling the baby's head and neck in towards the same side at the same time as the shoulders pass through a birth canal. So like doing this, what you've done is you've just stressed them and injured the nerves. You've torn the nerves. And when you tear any nerve, you may or may not function the way it's supposed to. And it may never recover, because we know that neurons don't often regenerate. So this Erb's palsy is a permanent injury. And you get pulled to one side, and it's a traumatic tear, traumatic stretching, violent stretching. Injury to the nerve also results in that carpal tunnel. Ulnar nerve. This is a big unexposed nerve. If you want to ever test your ulnar nerve, the best test for your ulnar nerve is to take your elbow like this and smash it on a hard surface. Everybody do that. Okay, maybe not. But what you're doing is, rather than smashing it, let's do something else. Here's your olecranian process. Here's your medial epicondyle, right? So here's my pinky. Olecranian process, medial epicondyle. Right here, right, that little groove right there, put pressure right there. Do it only on yourself unless someone gives you permission on them. And you want to put a lot of pressure on it. So you're going to push fairly hard. Where do you feel the tingling?
Up towards that side,
Up towards
right
what
up.
side?
like right up to your pinky
Yeah.
side.
Is it, and Is it all your full hand or is it just that half of your hand?
It's just that half.
Because that's where the ulnar nerve innervates. Your ulnar nerve is your biggest and most exposed neuron. The biggest let's put it this way, not the biggest nerve. It's the biggest exposed nerve that you have.
Would that be the nerve like when you hit what we call like your funny bone?
Yes,
But
that's
it
why I
just-
was saying if you smash it, you'll
It tingles.
Yes.
Gotcha.
So damage is your largest unexposed nerve. And damage to it can result in abnormal sensations in the fingers and inability to abduct or adduct your little ring fingers. My little niece, she just turned 14. And this last summer, she's been doing some very high risk, high adventure things that I keep trying to tell her not to do. And she doesn't listen to me very much. But one of the things that she did this summer was she put her finger through a plain glass window. She actually put 3 of her fingers. She and her brother were roughhousing, and he did something and ran out the door, and she started to go after him. And rather than opening the door to go through, she put her hand through the plain glass of the door. And she severed her ulnar nerve. And she severed it, because she has to put up with her aunt, who is an anatomist physiologist. And so the second I realized she'd been injured like this, I'm like, okay, well, where were you cut? What have you lost function of? And I have to ask all these questions, and she just has to tolerate it. But what she did, and I'll show it to you later when we talk about muscles and ligaments, but she cut it right here, and she cut through about 90% of it. It was quite the injury for something she did very quickly, because they estimate that by Thanksgiving, she did it in the end of July. By Thanksgiving, she may have full functioning of her hand back. But she may or may never receive full functioning of her and be able to, she may never have feeling in this part of her fingers because of how well she severed that nerve. The reason I told you she's been involved in high risk, high adventure stuff is she sprained her ankle like 3 weeks before she did this. And then just most recently, she sprained her other ankle. And she has to put up with her aunt, who says that she really should stop this high risk, high adventure lifestyle that she's kind of decided she's doing, because she just keeps getting hurt. But yeah, I learned a lot. And when we get to it in ligaments and muscles, I'll go into more detail with it, because I got I got a hold of the doctor's notes of what he did to repair it. And I got pictures because I wanted them. So the lumbar plexus is the L1, L4. It comes off the L1, L4, and it supplies the anterior lateral abdominal wall, the external genitalia, and part of the lower limbs. The femoral nerve is the largest nerve that comes off this plexus. This is the nerve that's going to innervate a lot of your lower leg, a lot of your leg in general. So damage to it can result in the inability to extend the leg, the loss of sensation in the skin over the anterior medial aspect of the thigh, And I'm trying to think. A lot of extension. So all of your quads, if you think about it, all of your quads, the muscles on your front of your thigh, you're going to lose innervation of those. So you won't be able to extend out your leg. Lumbar plexus, remember it's coming off L1 to L4. And the femoral nerve is the largest nerve coming off. Sacral plexus is L4, L5, and S1 through S4. And it's going to supply the buttocks, the peritoneum, part of the lower limbs, and give rise to the largest nerve in the body, the sciatic nerve. If you remember when you talked about the bones in lab, and if you learned about the greater sciatic notch, you remember that, the greater and the lesser sciatic notch of the os coxae of the pelvis. The greater sciatic notch the sciatic nerve runs in the greater sciatic notch. A lot of people struggle with damage to this that can occur with a herniated disc, a dislocated hip, or pressure from the uterus during pregnancy. And talking with my mom, it's not tingling, it's pain. I had someone in one of my classes say that when she was pregnant with her son, she would collapse because all of a sudden she just have no feeling in her legs. So sacral plexus, L4, L5, and S1 through S4. Then there's one coccygeal nerve that comes off the coccygeal plexus. If irritated, this nerve will cause hiccups.
C.
How did you know that right off the top?
Well, because we were just talking about how it affects breathing. What did you say?
Yes.
C3, C2, C3, C4? No.
Yep.
How did that little thing go? I don't know.
C3,
But I'm
C3, C4, and C5. Keep the diaphragm alive.
keep the diaphragm. Yeah, that one.
You're right. Yeah, you're right.
My recall isn't 100%, but that's what I
Hey,
was
it's pretty good. It's pretty good. Cutaneous innervation and dermatomes. Dermatomes are specific areas of the skin that convey sensory information from a specific spinal cord. So these are areas of the patches of the skin that are innervated by each specific spinal nerve. So each spinal nerve is going to innervate one patch of the skin. That patch is the dermatome. The dermatome map is a diagram of which patches of skin are innervated by which spinal nerve. They can overlap in their edges by as much as 50%. However, when there's damage to the spinal cord, knowing the dermatomes can help locate which region of the spinal cord has been injured. One way that you can really determine which spinal cord is innervating which dermatome is by looking at shingles. So shingles is an acute infection of the peripheral nerves by the herpes zoster virus. So one you're younger, you get the chicken pox. It's caused by the Varicella zoster virus. After you recover from the chicken pox, that virus remains dormant in the dorsal root ganglia. You guys, what's contained in the dorsal root ganglia?
Nerves that
Which nerves?
touch.
Yep. So
Sensory.
your sensory nerves, the cell bodies of the sensory nerves. And so the virus is held dormant there. In most people, or some people, it stays dormant forever and is kept in check by the immune system. However, if the immune system is compromised, you get stressed, you get sick. The virus can travel along the sensory nerve fibers in an anterior grade axonal transport and cause shingles, which is a painful trail of skin discolorization and fluid filled of the nerves along the dermatomes. Which can help the physicians determine what nerves specifically are being affected by the virus. Questions? So last part of this, we're going to talk about the natures of reflexes. We may actually move into chapter 14 today. Reflexes are quick, involuntary, stereotyped reactions of glands or muscles to stimulation. They require a stimulation, not a spontaneous, so they're not, they're not spontaneous, and they require sensory inputs. They're quick. Most involve few, if any, interneurons. So most are monosynaptic. We'll talk about that here in a minute. But monosynaptic meaning that the sensory neuron is going to synapse directly onto a motor neuron, and there's not going to be an interneuron in the central nervous system involved. So if there's the less synapses there's involved, the quicker it is. Reflexes are also involuntary, meaning they occur without intent and are difficult to suppress. Reflexes are stereotyped, meaning they occur essentially the same way every time.
Like say somebody has like, not verbal tics, but like tics that it's just very, I guess it would be involuntary because they keep doing it. And not knowing that they're doing it.
Yeah. Yeah, like Tourette syndrome.
Yeah.
Mm-hmm.
So with that, I guess that would link to.
I don't know exactly what that is, but it has to be uncontrolled stimulation.
Okay.
I can't remember what causes Tourette syndrome.
I don't know. It just came whenever you said that they're like quick and very involuntary.
Yeah. Yeah.
A lot of people can't help it. I mean, there's triggers, I'm assuming, but.
Let me look into it because I don't know.
Gotcha.
I think I knew at one point and I don't know now. A reflex arc, you guys, a reflex arc is the same thing as a feedback loop. Do you remember the feedback loops from a really long time ago? You have a receptor, you have an afferent signal.
And the control center.
What, Toyin?
I said the control center too.
Say it one more time.
I said control center.
Yes, yes. So you have a control center, an integrating center, and an efferent signal is going out, and an effector. That's the reflex arc. So a receptor responds to a stimulus by producing a membrane potential, producing an action potential on the sensory neuron that travels back, goes through the dorsal root ganglion into the dorsal horn. In the spinal cord, we have the integrating center. The sense motor neuron comes out, travels back, and goes out to an effector that gives us a response, provides the response. These can be monosynaptic, polysynaptics, ipsilateral, or contralateral. Testing these somatic, meaning skeletal muscle reflexes, aids in the diagnosing of many diseases. Monosynaptic are where the reflex arc is going to skip the interneuron. The interneuron is a middleman in between the sensory afferent neuron and the efferent motor neuron. Monosynaptic meaning that we're going to skip that part. And we're just going to have a sensory neuron synapsing directly on a motor neuron. Polysynaptic is where we have interneurons. Monosynaptic are going to be faster because there's going to be less synaptic delay. If you have less synapses, you have less delay. Polysynaptic, you're going to have more delay. They're going to be slower. And ipsilateral is where the stimulus comes from one side of the body and the response occurs on the same side of the body. So the sensory signals on the same side of the body that's going to respond with the motor output. Contralateral, meaning the stimulus is going to come from one side of the body and the response is going to be on the opposite side of the body. This in mind, a stretch reflex or the patellar reflex, a muscle is stretched and it fights back and contracts. Let me show you an example. And if my mom was awake, I would have her do this for me. But she's not awake, so we're going to do it by myself. Can't see it. I have really, I have kind of hyperactive reflexes. I'm going to try to angle this so you can see it reasonably well, my knee. So here's that patellar ligament right here. The quad muscle contracts. Muscle spindles that are receptors in the muscle are going to sense that, and that sensory signal goes back via the dorsal root ganglion into the spinal cord. It synapses with a motor neuron that comes out and results in those muscles contracting and the hamstrings below relaxing to allow you to contract that muscle. So there's a couple things that are occurring here. The response is going to be that the muscles, your quads are going to contract while your hamstring muscles are going to relax to allow you to actually extend out your knee. So contraction of a muscle always results in the relaxation of another muscle. So these stretch reflexes help to maintain equilibrium and posture. Questions? The receptor in this case are the muscle spindle fibers, which are receptors that respond to stretch. There's two alpha motor neurons. One sends an inhibitory signal to cause the hamstring muscles to relax. And another neuron is going to send a signal to the quadriceps to have them contract. A flexor or withdrawal is combined with a cross extensor reflex. So the flexor withdrawal is when you step on a nail. When you step on a nail, what happens? You immediately pull up your foot. And the way you pull up your foot is by triggering the contraction of the flexor muscles, those hamstring muscles, and relaxation of the extensors or quads. So this idea that you would avoid muscles working against one another is that you contract one set of muscles while relaxing another set of muscles is what we call reciprocal inhibition, which prevents muscles from working against each other by inhibiting the antagonist and activating the agonist. That's the withdrawal reflex. The cross extensor reflex occurs so when you pull up your foot, you don't fall over. Because what happens is you contract, you relax your extensor muscles while contracting your extensor muscles on your other leg to keep you upright. By stabilizing you. So I don't know how well we're going to see this. We'll try a little bit. So I step down on something and I immediately pull up my foot. And at the same time that I pull up my foot, my other leg extensors are going to contract to keep me from falling. So these muscles relax, these muscles contract. And the extensors on my opposite leg are going to contract. That's my cross extensor. My extensors here relax while these contract. I don't know how well you saw that. I hope you saw it fairly well though.
The reciprocal inhibition is just when one contracts, the other relaxes.
Yeah, the opposite, the one keeps them from working against one another.
So it's the opposite.
Yeah, I mean, it essentially is allowing one set of muscles to relax so that the others can actually contract.
Okay.
this, excuse me, this, the flexor reflex is an ipsilateral, meaning it's happening on the same side of the body. The crossed extensor is going to be a contralateral reflex arc because it's occurring on opposite sides of the body. One side of the body the extensors on one side of the body are being relaxed, while the extensors on the other side of the body are being contracted. That makes it a contralateral reflex. Intersegmental means that it's occurring at multiple segments along the spinal cord. Because what happens when you flex your leg? When you're standing and you flex your leg, your abdominal muscles also contract. So that's an intersegmental reflex, because it's involving multiple segments of the spinal cord. Questions? Which statement best describes reciprocal innervation? Or reciprocal inhibition? How did we have it up here? Reciprocal inhibition.
A.
Say it again.
A.
A.
Wait, hold on. I'm sorry, B.
It's going to be B because it's going to happen at the same time.
Right. I use this all the time in massage. Like if you get a foot cramp, you
Yeah.
can activate the opposite muscle in your foot to like help relax.
Oh,
Like,
really?
I do it a lot for like in practice to help relax like the opposite muscle.
Wow. Okay.
Yeah. Well, it's not really called opposite muscle, but you know what I mean. Like
Yes.
if the bottom of your foot is cramping, then you can like contract. Like I just have them push like the top. I hold the top of their foot while like they're pushing up on it, and it relaxes the bottom of the foot. Like
Oh.
get rid of the cramp.
Okay.
Anyway.
Cool. All right. Babinski reflex is the way it works is you stroke the medial side of the foot and move up against the top of the toes. So you start at the very bottom of the foot, you move up the medial side and then across on right underneath where the toes are. I don't know about you, but if you've ever had this done, for me, it tickles. And the first response that normal, healthy adults have is that their toes curl in. Their big toe especially curls in. In babies up to about a year to a year and a half, their toes will fan out.
Marco, come here.
Their toes will fan out. So if the sole of the foot is stimulated and the patient extends their big toe, it indicates that there's damage to the corticospinal tract. Young infants will normally extend their toes when stimulated in this way. So it's the myelination that isn't there yet. You have to wait for it to develop. So last slide, trauma to the spinal cord. Complete transection is a complete severance of the spinal cord. The result is that there's immediate loss of motor control below that level of injury. Anything above the C4, C3 is going to pose a threat to respiratory failure. Paraplegia is paralysis of the lower limbs. Quadriplegia is paralysis of all four limbs. So quadriplegia C3 to C1. Paraplegia is C6 to C7. Hemiplegia is L1 to L2. Paresis is more L10, T1 to L1. I'm messing them up. T10 to L1 is hemiplegia. L1 to L2 is paresis. Any questions about the spinal cord in this chapter?
You just said T10 to L1 for Hemi, right?
Yes.
Yes.
And I don't know how exact that is. That's just an estimation.
What of paraplegia?
Say it again, Toya.
Paraplegia.
Paraplegia is C6 to C7. Because above that, remember the cervical plexus is what's going to produce, oh, I'm sorry, not the cervical plexus. Below C6, if you have a break above around C6, C7, if that's not intact, you will still have the, if that's intact, sorry, but right below C6, C7, you will still be able to use your upper limbs, but you will not be able to use your lower limbs. Other questions? All right, so let's jump into chapter 14.
So my question, I'm sorry.
Go ahead.
The chapter 13 quiz and practice.
That's what I was just going to answer that. They will be due right around next Wednesday at midnight.
Wednesday. That will be 15th.
Yes.
Okay.
Is it? No, it's not the 15th. Wait.
No, McGraw-Hill has chapter 13 quiz due the 15th, and then chapter 13 practice due November 22nd. They're different dates.
I will extend, well, the practice, I let that stay open until the opening of the first exam.
Okay,
The second exam, the exam on that chapter.
gotcha.
And that's the reason I do that, is to allow people to use it to practice.
Okay,
But the quiz and the smart book assignments will both be due not the 15th.
because the smart book assignment was due yesterday, according to McGraw-Hill.
I'll extend it out to this, and so it will be due. I cannot remember what 14th is Sunday, 15th, 16th, 17th, the 17th.
Okay.
Hi. I need to write that down. November 17th.
Yeah, because like I said, the dates with McGraw-Hill and the dates with D2L are two totally different dates.
I don't know why they do that. They should run parallel, but because they're connected,
Mhm.
know why they do it though.
Listen, as long as we know the dates,
Life is
I can
good.
disregard and care less. But
Okay.
Yeah, I was gonna say in my McGraw Hill, it's always like doubles of like the items.
yeah, mine too.
I don't know why that's the case either.
Yeah, it's like weird, but it says like my stuff's late, but it's like doubled, so I already did it, but I'm just like,
Yeah, I looked, if you go in McGraw-Hill and you look at like what you haven't done, because I was having a blonde moment the other day, and I actually emailed the Professor Gessel. If you look beside the assignment and it says see report, it means you did it, because the seeing report is like the grade that you got on
oh, okay,
that
actually
specific
helps.
assignment. Yeah. So
Like-
with doubles, you're just like, you know, you did it, but it's not showing up.
Like a
and it's
double
just-
check for yourself. Yeah.
right. So like I was looking and I was like, I know I did this. And then I read through and it's a link. It's like a little hyperlink that you can click next to the assignment that says see report, and it'll show you the grade. So you know you already did it.
Okay, perfect. Because I'll always be in there. I'm like, oh my God, wait, did I not do this?
Yeah.
Okay, so moving on to the brain and the cranial nerves. So the brain, extremely complex. It weighs about 3 pounds, and it simultaneously conducts and coordinates a variety of processes with which no computer has ever been able to compete. This is a typo here, obviously, but the brain's function is clinically associated with what it means to be dead or alive. All these functions and many others occur within 85 billion neurons and 10 to 50 trillion neuroglia. One thing that we're going to learn here is that the functions of the brain the brain is probably the thing we're most fascinated with as physiologists and anatomists, and the one that we know the least amount about. And you know, one thing that any really successful scientist, which you all are at this point, any successful scientist recognizes how little they know about things. The second you think you know everything, you've reached the roof of how far you're going to move. And we will learn in this chapter that the brain its functions are much greater and bigger than the sum of all its parts. So the brain in early development, it forms from a neural tube that forms 3 bulges. And each one of these bulges are going to produce a vesicle. The prosencephalon, the mesencephalon, and the rhombencephalon. Pro meaning the forerunner, mes meaning the middle, and rhombencephalon meaning the back or the tail. So the forebrain is going to be formed from the prosencephalon, the midbrain is going to form from the mesencephalon, and the hindbrain is going to form from the rhombencephalon. What does encephalon mean?
Ed.
Cephal means head in medical terminology.
Yes. So think of it this way, and encephalon is the brain. A really nasty birth defect is anencephalon. What does that mean?
Your brain hasn't formed.
It doesn't form. I have a really good friend, and when I met her, probably the second week that I'd known her, she said, "I've never told you about my son." And I didn't realize she had any kids. And so she started showing me pictures of a baby, and he had microencephalon. And he died when he was about 18 months old, almost actually 21 months old. He was born on September 11th of 2009. And he died almost 2 years later. And she said, looking at his brain when they went in for an ultrasound, they just realized he was missing. You look at the cranium and you just don't see any tissue there. There's just major dark spots. And so, yeah, he died at 21 months of age. I'm going to ask you before we finish this chapter, how did he survive for that long? Anencephaly babies are born, they are almost always live births, but they tend to not survive for more than a few hours. Well, how do they survive at all? Don't answer that question if you already know the answer. We'll come to it. But let me go ahead.
When I was at the Real Bodies Museum, we went in Vegas, and they actually had one. I have a picture of it, and like it's so sad, but it's so interesting at the same time, because it's like it was real. And this baby was not even as big as, like, if you put two of your hands together like this, like that's how big the baby was.
Really?
Yes. But its body was like normal, and the head was just it was rounded, but it was very flat.
Yeah, the neural tube fails to close. And when it fails to close, it's open to the amniotic fluid, which essentially destroys it.
Yeah, it was interesting. I mean, like I said, it was sad, but it would, because it's all real and they just preserve it. But it was interesting to see.
Yeah, it's really, really quite sad. And you know what? I wanted to actually, let me do something really, really quick here. So the prosencephalization is where the prosencephalon, so the forebrain and the hindbrain, are going to divide to form 5 major brain vesicles. Ultimately, these 3 vesicles are going to form through encephalization, are going to form 5 vesicles: telencephalon, the diencephalon, the mesencephalon, the rhomencephalon is going to form the metacephalon and the myelencephalon. Of these 5 different vesicles, these are the different structures that are going to form. And we will talk about all of these different structures. But one of the first objectives for this chapter is to know what forms from what. Use this as a diagram. It isn't in your book. I made this up. Use this and memorize what forms from what. Because if something fails to form, if one of these vesicles does not form, you lose those structures. And have a wonderful weekend.
All right, thank you. Bye-bye.
Thank you. Bye. Thanks. Have a good day.
Thank you.
You're
Thank you.
welcome. Karen, Ashley, are you still here?
Yeah, I just had a quick question for you.
I know you
So-
sent me an email too.
Yes, I did. And it's about the same exact thing. I don't know what I was thinking when I looked at the assignments, but